From there. Should be good.
Sounds good.
All right.
Do I got that clicker thing?
Let me see if I can find it.
I can just hang out here.
I'll see if I can find that. So how was the break?
Probably not.
Probably not good. Is that what you said?
I went from really wanting to study to having no desire to.
So when you took one day off, is what you said?
No, I took too many days off.
We can skip over all these objectives.
But this is Gary's. Nope. I don't have a Bluetooth chip, and I couldn't find it on his desk. Unfortunately, I got a manual one.
All right.
To get one of these for the group.
Can't see anything mouse wise. Let's go. All right. We're gonna go over just a quick review, anatomy wise. You guys know all this stuff. You guys hopefully know where the heart is, right? In the mediastinum. 2/3. One bit of information. 2/3 of the heart is left of the midline of the sternum. I don't believe that's necessarily important testing wise, but important to know anatomy wise. So when we're talking about, I guess, terminology, it's kind of a misnomer, but the base of the heart is the upper portion of the heart. Apex is the lower portion of the heart. Which ventricle is, or which chamber of the heart is the apex? Left ventricle, good. Let's see. So yeah, muscle, cone-shaped organ. It's about the size of a person's fist, which really isn't all that big, not as big as you would think. And these are kind of just average dimensions of the heart, not something that you have to memorize, but just gives you an idea of how the size that we're talking about. This is obviously a review. You guys know about the chambers. We've talked about the chambers before. 2 upper chambers are the atria, 2 lower chambers, ventricles. And you guys understand how the blood is pumped in and out of the heart through the pulmonary system. You guys know the ins and outs of all that stuff. I don't think we have to go over that slide too much. So the two functional pump. What's stroke volume?
Blood each stroke puts out.
Wait, what?
How much blood each stroke puts out?
Okay, yeah. How much blood each stroke or contraction is pushed out? So what's the ejection fraction?
How much of the blood in the ventricle
Is actually pushed out? How much on the average? How much blood percentage-wise is pumped out of the left ventricle? 40 to 50% on average. So when you see anybody with CHF, they usually know what their EF is. All right, when you go and pick up a patient that has chronic CHF, usually you can ask them, "What's your EF?" And they know what their EF is. They might not know what EF stands for, they might not know what it means, but they know what that number is. They're like, "Oh yeah, my doc said my EF is 10%," and then you know that you can't give them really any fluids, or it's going to drown their lungs. So EF score, 40 to 50%, even a little bit higher than 50% can be normal. Anything below 40% starts to become abnormal. And we'll see EF scores down to 10%. You don't really get below 10% because when they get around that 10% mark, they're usually they either have to be really careful or they just don't have a whole lot more time left.
A question on that, is that just dealing with the ventricle? Or do they also measure the atrial?
That's the left. Well, I mean, ejection fraction in general can be any of the chambers. But when we talk about the EF score on an echocardiogram, it's from the left ventricle. Because they care about how much, the percentage of blood that's being pushed out into the circulation. Let's see here. So surfaces of the heart, I mean, this is important when we start to understand EKGs and which part of the EKG is which section of the heart. And when we get into the EKGs a little bit more in detail, we'll talk about that. But anterior, you can see where the septal portion of the heart is, that inferior portion, then your lateral, and the different blood supplies that feed the different areas. We'll talk about those as well, because that's where your infarcts come from. Lack of blood supply, right? So more review. You guys know what endocardium, myocardium, epicardium is, right? You guys know what the pericardium is as well. Pericardial sac. Good. So let's see. You guys understand endocardium, innermost layer, lines the heart chambers, continuous with the innermost layer of vessels. So the endocardium is lined with what kind of cells? Epithelial cells. Good. And they continue with the layers of the vessels. So the endocardium continues up into the aorta, continues with any of those vessels that are coming in and out of the heart, right? So it's all continuous and contiguous. Myocardium, that's that middle, thicker layer. That's where all your pumping action is. The epicardium. This is important to note that this is where your blood supplies. This is where all your coronary arteries and veins are. And then, you know, they kind of travel along the epicardium, and then of course they branch off and go deeper. But it's important to know because the epicardium is the first layer that receives blood, and then the myocardium, and then the endocardium is the last layer that receives blood. So what do you think when you have an infarct is the first layer to die? Endocardium is the first layer to die, and then myocardium, and then epicardium. Does that make sense? It's the last one to receive blood, so it's going to be the first one that doesn't get it, right? All right, pericardium. We've talked about the parietal pericardium and the serous pericardium, and then the space in between, and that acts as a cushion, right?
The loss of blood flow to the endocardium, would that normally present with any symptoms, or is it only until the myocardium, which is blood supply?
You'll still have some symptoms from it, but I guess the big functional deficits come from the myocardium when those cells start to die. So the problem with buildup of blood supply in the pericardial sac, what's the problem there? What's that? Tamponade. That's what it's called. What does it do? What's the problem? Does it affect contraction?
Yes. Blood pressure on it, contractile force.
Okay, so it can decrease the contractile force because where does your contractile force come from?
The expansion of the heart and having enough.
Right, the right dilation. So the big issue with tamponade is that you have no refill, right? You can't fill the heart appropriately. You don't get the stretch of the fibers, and the stretch of the fibers have to be in a certain pattern for it to have really good contraction, right? Those sarcomeres have to be at the right spacing to have good contraction. Okay, good. So this is kind of a review of the muscle fibers themselves. So cardiac muscle is only found in the heart. This is very specific kind of muscle fibers. I think the big difference between this muscle and a lot of your other skeletal muscles and smooth muscles is the intercalated discs. What function do those discs play? You guys remember? Well, there's a lot of differences between this muscle and other muscles, but one of the big ones is those intercalated discs.
So your gap junctions are?
Those are where your gap junctions are, and what do the gap junctions serve as? The conductivity, right? So if they're skipping, if that electrical system, once it goes through the conductive cells and your SA node, AV node, bundle of His, bundle branches, Purkinje fibers. Once it goes through that, it goes into the muscles, right? And then how does it spread through the muscles? Those gap junctions. So that's an important aspect. Also, the heart. Do you think it has more mitochondria or less mitochondria? More, a lot more. Good. Let's see. So these are two different fibrils inside those sarcomeres of the heart muscle. Important to know is basically the actin strands and then the myosin strands. And when calcium binds, changes the composition of one and enables the binding to the other. And then it kind of creates this action where it's all contracting and pulling on each other and creates those cross bridges. Troponin. Did you guys know that troponin was part of the myofibrils? Or did you figure it was just the name of some lab test?
Well, that's what calcium binds to.
Right? Right. So calcium binds to the troponin. When heart muscle dies, those proteins are degraded and released into the bloodstream because they break off from the myofibril strands and they get into the bloodstream to be broken down and reused amino acids for the body. But some genius came up with a way to measure the troponin concentration in the bloodstream because troponin, that's the only muscle fiber really that has troponin. We used to measure, do you guys know what we used to measure for heart attacks? Creatinine kinase. And creatinine kinase, the CK levels, you can find in all muscles, right? Skeletal muscles anyway. When you have a hard workout or whatever, and you've got little tiny breakdowns of muscle fibers throughout the body in those big muscle groups, you'll have increased levels of creatinine kinase. So it wasn't a completely accurate test. Now you could differentiate between the creatinine kinase MB, which was cardiac, and the total creatinine kinase, but the troponin level was much more accurate. And now we have the iStat troponin. It wouldn't be cool if we get the iStat troponin in the buses. Just do a little blood stick and you could see where you're at. So if any doc on the phone was arguing with you about an EKG, be like, dude, troponin's 5. So we talked about the intercalated discs. That's where the muscle fibers connect together. That's where your gap junctions are. They function as the electrical connections and allow that electrical impulse to travel through the muscles. This is a posterior view of the heart. It gives you kind of an idea of the skeleton of the heart, which is all the fibrous connective tissue that make up your rings and your valves. And that is what anchors the heart in place so that it's not moving around because it's contracting and squeezing, and obviously could be jumping around quite a bit if it wasn't attached. We know about the valves. We'll go over that real quick though. 2 sets of AV valves. You guys know what the names of those AV valves are? What's between the right atrium and right ventricle? Tricuspid valve, and on the other side you've got the mitral valve, which is a bicuspid valve. Good. And then your semilunar valves, those are what? Pulmonary and aortic valves. Good. So the function of those valves is basically so that blood flows in one direction and cannot regurgitate, right? Prevents backflow, and we'll talk about how and why. So the AV valves have chordae tendineae. On the right side is the tricuspid valve. It has 3 separate leaflets. So those leaflets are connected by the chordae tendineae, which are then connected to the papillary muscles. Papillary muscles are part of the muscular structure on the inner layer of the heart. What function do you think the papillary muscles and chordae tendineae have? What do you think they do? They what?
Keep it closed.
Okay, yeah, exactly. So it makes sure that the valve doesn't prolapse. Sometimes you would think that, I guess, logically, you would think, oh, well, that muscle contracts and it pulls those cords down and it helps open the valves, right? But it doesn't help open the valves at all. Flow of blood is what opens the valves. It's just a pressure gradient, right? The chordae tendineae are only in the AV valves and not in the pulmonary aortic valves. Why do you think that is? There's a lot more force, right? That's where the ventricle is. And as the ventricle's squeezing, there's a lot more force pushing against those valves, and it needs that extra support to kind of hold those valves closed so that there's not regurgitation of backflow. Good. Left side, mitral valves, only has the 2 cusps. We talked about this. Chordae tendineae are also called heartstrings. That's just kind of a nickname. But like I said, they're more anchors for the valves. Semilunar valves. So they also prevent backflow, but there's not as much of a pressure gradient there, so they don't need the papillary muscles and the chordae tendineae to help hold those closed. It's all based on flow, right? All right, so first heart sound. First heart sound is, when you're talking about that lub-dub sound when you're listening to the heart, that first heart sound is called S1, and that's the AV valves closing. Which AV valve closes first? Right side. So the tricuspid will close just milliseconds before the left. And sometimes you'll hear a separation. In kids, you'll hear a separation with just their breathing patterns, because with kids, the variations of that increased intrathoracic pressure when they breathe in will change the pressure gradient enough that there'll be more of a space between the closing of the tricuspid and the mitral valves. So sometimes you'll hear 2 S1 sounds, and it'll be more separated. You can really differentiate that. Say if you have a kid take a deep breath in and hold it, like you can go listen to your kids at home and have them take a real deep breath in and hold it, and you can hear a little skip or 2 portions of that S1. Doesn't happen in adults because we don't have we don't have the I guess the sensitivity in differentiating the two unless there's disease. When there's disease, then those valves will start shutting at different times, like significant LVH, congestive heart failure. Depending on if it's left-sided or right-sided, you can hear the differences. So the second heart sound is when the other valves close, right? So systole is in between S1 and S2. And then as soon as those semilunar valves close, that's when you have diastole, right? You have relaxation. Does that make sense? So when you start to hear murmurs, and you hear a murmur between S1 and S2, you know that that's a systolic function. That's during contraction of the heart with blood flow. So that could be, depending on what kind of murmur you hear, could be an issue with the valve itself, and you're hearing a difference of how the blood rushes across that valve, or it can be regurgitation. So when that heart starts to contract in systole, if the valves have a defect and there's regurgitation back instead of where it's supposed to go, you'll hear a certain murmur. And then on the opposite, if you hear it between S2 and S1, I mean after S2, then you know that that's diastolic. And you can differentiate and decide where and what kind of murmur that is depending on when you hear that in the cycle. So third heart sound, it's normal for younger people. Really anybody below the age of 40, you can start to hear that third heart sound, and it's sometimes it's called a gallop. What do you think it's caused by? It's caused by ventricular filling. You wouldn't think that filling of the ventricle would cause a sound, but there's a pressure gradient there, right? And as soon as that pressure gradient gets to a certain point, it's able to push through the valve, and that ventricle still has some blood in it, and you get that sound of liquid hitting liquid, right? So you get kind of a gallop sound, and you'll hear that in younger people. It can be both. Yeah. It's actually more on the right. Why do you think? There's a little bit higher gradient going from the body than there is from the lung. So we know the blood flows from the heart. We know when it's oxygenated and deoxygenated, right? All right. So systole, this is the period during contraction. You guys understand systole. During systole, you've got blood flowing both to the lungs and to the body, right? Diastole is relaxation. And this is when you've got blood flowing from the atria to the ventricles. Do you think most of the blood filling into the ventricles, do you think that that's during contraction, or do you think that's passive? And that's from the atria into the ventricles. Passive. Good. So about 70% of the blood is already in the ventricles before the atria even contracts, right? When the atria actually starts to contract, the rest of the blood gets pushed into the ventricles, and that's called an atrial kick. It's kind of the last and I guess the rest of the blood. So atrial diastole. So this is when blood is entering into the right atrium. Atrium fills and distends, gets to a certain pressure, and then that tricuspid valve. Well, actually, during filling, tricuspid valve, it doesn't take much for that valve to open, and then you start getting this passive filling as the atria is filling the ventricle. It also starts to fill as well. Left atrium and ventricle, same way. And like I was talking about before, as soon as that atria contracts, just like milliseconds before the ventricle, it pushes the rest of the blood in there. So I mean, it's kind of I mean, it's an amazing system, incredibly efficient. And when you really get into the science of all of it and all the pressure gradients, how the valves work, and it's like so quick, like the atria contracts and then milliseconds later the ventricle contracts, but that valve is already shut because of that pressure gradient, and it's able to push blood where it's supposed to. And that's why, you know, even what's crazy is that as specific and efficient as the heart functions, even with defects like big holes that like septal, you know, your ASDs and all your different defects with the tetralogy of Fallot. You know, you've got the 4Fs, all these different, and people, you know, can still function and live with these huge defects that you would think would throw off this very precise and efficient system, but the heart and the body kind of compensates and is able to, for the most part, get away with it unless there's a huge defect that needs to be fixed. So we know this ventricular systole. This is the AV valves close, SL. Okay, so this is more of a kind of a timeline. This is after the blood is propelled through, and then the SL valves close, and then you've got ventricular diastole. That's when you got filling. Coronary arteries. Coronary arteries branch off of what? It's pictured. Where's it coming from? The base of the aorta. Right. So when do you think the heart gets blood? During which portion of the cycle? Diastole. Why do you think the blood or the heart receives blood or gets its blood through the coronary arteries during diastole? So yeah, there's, as soon as those semilunar valves close, right, there's backflow, everything's relaxed, and you get flow into the coronary arteries. Physics-wise, why does it have to happen during diastole? Why couldn't it happen during systole? You got blood pushing into the aorta at a huge pressure gradient. Why can't there be blood flow into the coronary arteries?
Is it because least resistance is going into that big aorta?
It's because the muscle's contracting. All of those arteries and veins are constricted and squeezed, right? They're pushing blood out just as much as there's blood being pushed out of the ventricles. There's a pressure gradient there, and there's no blood can go into them because they're contracted and squeezed as well. Also, the semilunar valves pop up and kind of block the pathway. So that's why it's so important. If you want increased blood flow during a heart attack, what do you need to do? You want to increase diastole, right? How do you increase diastole time? Slow the heart rate down. That's why we give, you know, in any person having a heart attack that's tachycardic, we give them a beta blocker. We slow their heart rate down. Decrease the work on the heart, right? So if those blood vessels need to be relaxed, that means they need to be dilated. What's a medication that we give to just about everybody to achieve that dilation? Nitro. So that's the point of nitro, to dilate the coronary arteries so that you can get increased blood flow, right? All right. Coronary veins all dump into the coronary sinus. Coronary sinus dumps into the right atria, right? All right. So arteriosclerosis and atherosclerosis. Arteriosclerosis, or I should say atherosclerosis, is a form of arteriosclerosis. So what's arteriosclerosis? I guess the definition's right there. You guys can cheat a little bit. So it's just abnormal thickening and hardening of the vessel walls. What causes that?
Age?
Okay, age, certainly. Overuse, certainly. High blood pressure. All right, that's why we want to control blood pressure. High blood pressure, if you have an increased pressure gradient, then the vessels try to compensate for that increased pressure by thickening its walls, trying to make it harder and stiffer. That hardness and stiffness makes the function of that vessel worse, right? It can't control its own pressure. Atherosclerosis, what's the difference?
Plaque buildup, right?
Right, so that's buildup of your fatty deposits. So you get buildup of that, you have decreased blood flow, increased resistance, yada, yada, yada.
More like a high cholesterol kind of thing, or
High cholesterol is part of that. So your cholesterol is those fatty chains that are in those fat deposits. So any artery in the body can develop atherosclerosis, which includes your coronary arteries, right? And that's where you get angina from. What's angina? Well, it's chest pain. What kind of chest pain is it?
chronic, or is it acute? Sleep.
Coronary.
It's exertional chest pain, right? You've got blood vessel and you've got plaque buildup like that. Under normal circumstances, at rest, when there's not demand from the heart for increased blood flow and increased oxygen, the heart can do just fine with that plaque buildup, right? But if that heart starts to start working harder and requires increased blood flow, requires increased oxygen, its demand is increased, but not enough flow can get to it, right? So there's not enough gain for the demand, and that's when they start to get exertional chest pain. They're working a little bit harder. If that heart is requiring more, but it can't get it because the flow is not there, that's angina. And that's why nitro helps with angina. You dilate those vessels and you get that increased flow again, right? And nitro and rest. Somebody's having chest pain, you don't want them to move, right? I mean, you hear stories all the time where a guy, is whatever, out hanging with his buddies. Oh crap, he gets that chest pain. He sits down, his buddy's like, okay, stay here, whatever. And the guy's like, whatever, I'm fine. And he gets up, he takes 2 steps, and he's gone, right? And he drops. And that's because at that point, there's such a sensitivity on the balance of how much blood flow and that cardiac muscle. And if you increase the work of the heart even by just a little bit, that tips the balance, and then those muscles, all that cardiac muscle dies, and it's just enough to, stop that patient from having functional contraction, no more blood flow, and boom, they drop. So you got a guy with chest pain, you don't want them to move. You want them to rest, sit down, lay down, whatever. But of course it can happen. Atherosclerosis can happen in other parts of the body, right? If it's in the legs, we call that peripheral vascular disease. Somebody has peripheral vascular disease. What are the kind of things associated with peripheral vascular disease, or what kind of diseases? So diabetes is one of them, yeah. So you can get diabetic neuropathy from peripheral vascular disease, right? Diabetic neuropathy is because there are little teeny tiny capillaries and arterioles that are feeding the nerves, right? Well, if you have decreased blood flow, those are the first ones to not get the blood flow, right? So the nerves start to break down and die, and damaged nerves equals nerve pain, diabetic neuropathy, right? You also get claudication. You guys know what claudication is? So claudication is basically angina of the legs. means that when they start working hard, they get pain in their legs, and they're I don't know why every time I start walking around the mall or go shopping or whatever, I get pain in my legs, and it's angina of the legs. It's the same concept as angina, right? It's exertional pain in the legs. It's called claudication. So that's why history is always so important. If you can get a history, get a good history on all of the patients that you go pick up. Especially because sometimes if you guys don't get the history, nobody gets that history, right? Things happen, stuff changes, family goes to the wrong hospital, whatever. If you guys don't get the history, the doc never gets the history, and we never find out or know what it was until sometimes it's too late. So that it can also happen, of course, in the carotid arteries. It only has TIA here, but obviously it can also cause full-blown strokes as well. But that's atherosclerosis. So yeah, we talked about angina. So these are just the kind of different things that you'll hear patients describe, and it all means the same thing. Heaviness, pressing, suffocating, squeezing, strangling, band across my chest, burning. The burning one is tough because burning also usually for most people means what? What's that? GERD, reflux, right? Just about everybody has GERD and reflux, seems like. So burning in the epigastrium, you're like, oh, well, that guy's got reflux, he's got ulcers, whatever. Well, that could also be a heart attack. So get EKGs on everybody. These are the sites of discomfort. Shoulder pain. It'll be interesting is sometimes patients will, in order to try to come up with an answer to their own pain, will tell you information that really is probably not true. Like they'll have shoulder pain, and in their mind, they don't want to think that it's a heart attack. And even if they already know that, well, maybe that means heart attack, they'll come up with a reason. Well, last week I was reaching up to grab, and I think I felt a little something in my shoulder, and I think it's just that, I think it's just, and so you're like, oh, well, I've got a cause for the shoulder pain. It's not the heart. Patients will make up stuff, and that happens all the time.
Isn't that one of those situations where it's easy to lead the patient to having pain and need everywhere?
True. Absolutely. And oftentimes patients will, they see you guys as an authority figure, and oftentimes they'll tell you what they think they want you to hear, or what they think you want them to say. So if you come across as in you don't want them to have a heart attack or be having a heart attack, or you don't want to have to deal with them having a heart attack, they'll pick up on those little cues, and they'll go down a story that they think will make you happy. It's interesting how often you see that too. So ischemia is that imbalance, right? Where there's not enough flow for the demand. And that's why to improve the situation, you add rest, you can give medications, increase blood flow with nitro. What's a situation where you don't want to give nitro? Okay, low blood pressure. What kind of heart attack?
Oh, on the backside, right?
Inferior or posterior. Because what can happen? The inferior is which side of the heart? Inferior, posterior is usually which side of the heart, which blood supply feeds that, right? So that's usually right side of the heart, right coronary artery. And so you give nitro, sure, that dilates the coronary arteries, can help blood flow to the heart muscle, but it also dilates what other arteries? All of them, right? So nitro is not selective. So it'll cause vasodilation everywhere. So it'll decrease your preload as well. And if you already have a problem with the right side of the heart, really tanks their blood pressure. You tank their blood pressure and then they don't have flow, do they? Right? So that makes their ischemia worse. So you have to be careful with inferior MIs and not giving nitro. Sometimes it can still help with the pain, but it can make the situation worse.
Talk about that real quick one more time. Inferior MI with back pain.
So inferior MI, or oftentimes an inferior is an inferior posterior, because it's all with the right side of the heart. It's with the RCA. It's the right coronary artery. So that's a heart attack of the right side of the heart. This is where all of your preload is coming to, right? So if you've got muscle that's already dying in the right side of the heart, and then you decrease the preload, then you're decreasing any blood flow that's then going to get to the left side and then be able to be pumped out, right? So you're decreasing your preload overall. Not only are you decreasing preload because that's what nitro does, but because you're decreasing that on an already crappy right side. Does that make sense? So that's why you got to be careful with giving nitro on inferior MIs.
So is that just not very common?
What?
Inferior, posterior?
No, inferior MIs are, I guess, statistically, they're probably, 30 to 40% of MIs. And that's just because, the RCA, you've got RCA, and then, a lot of your blood flow goes to the LAD, branches off into the circumflex. So you get heart attacks into the circumflex, the LAD, and then the RCA. So from a percentage-wise, there's really not one that's more common than the other than which one is just getting more, I guess, covering more area. But they're common.
Because I know that they've been pushing, especially for the basics.
Pushing nitro?
Pain calls, they've got a PPE that's over 100, nitro and aspirin. And they've even sent emails saying, hey, you guys with ALS on scene with this, you should have given this. So does it, does it overweigh the risk versus reward?
I think in general, just because of the time restrictions that you have on an MI, that might be just an overall, decision, so that they don't have people that don't understand the process thinking about it and then not giving it because they think they're going to do more harm than good. I think, they've probably looked at all the statistics and said, it's going to do us, we're going to save more people if we just give it. And if their blood pressure is not terrible, then that's probably why they say if the systolic's over 100, give it. Because one, they're not getting EKGs, and two, not everybody's going to be able to read the EKGs correctly. So if the blood pressure is good enough, they're probably the thought is that, well, if we give, they've got enough blood pressure that it's not going to get, terrible.
If you're giving a lot of fluids, is that going to help out the situation too?
What do you think? What does fluid do?
It's going to either go on the lungs or increase preload.
Okay, so fluid will increase preload. It also, as you get increased filling of the heart, you get increased what? Frank Starling forces. Increased filling, you get increased what? Contraction. So what does that do to the overall work of the heart? Increases it. What do you not want to do in a heart attack? Increase the overall work. So that's why, sometimes you can't just do the empiric, lower blood pressure, give them fluids, right? You have to think through situations and decide what is my best course of action. If you already are assuming or have evidence that this is a heart attack, well, then you got to treat it like a heart attack. Don't give them a bolus because their blood pressure, if their blood pressure really is terrible, then, anything's better than dead, right? Then you're at a situation where, well, if I don't increase the blood pressure, well, then they're not getting any flow to the heart. So, but that, I mean, if you're kind of on the border and they're around 90, they're around 100 systolic, even 80 systolic, then maybe you should hold off those fluids. If you're hearing rales in the lungs, do you want to give fluids? If you're hearing rales in the lungs on a patient that has no history of CHF, what does that mean?
It's a pulmonary flash edema.
Flash edema, so pulmonary edema. What causes pulmonary edema? Either a bad pump or damage to the lung tissue, right? So damage to the lung tissue really only happens like if they were on a fire, if they were working in a factory and were breathing in a whole bunch of chemicals and they've got damage to the lung tissue, and then they get fluid, that's accumulating because of damage to the basically swelling of the lung tissue, right? Your lung tissue swells just like any other part of the tissue, but if your lung tissue swells, that's pulmonary edema, and that's affects your ventilation. But for the most part, the most common reason for you to get fluid in the lungs is because the pump sucks, right? Because there's a backup from the pump into the lungs. So if you've got a patient that has pulmonary edema and rales and no history of CHF, what does that mean? It means that their pump suddenly became crappy. Why did their pump suddenly become crappy? Because they're having a heart attack. So even if they're just complaining of shortness of breath and you listen to the lungs and they have rales, you have to assume this is a heart attack until proven otherwise, right? All right. Injured cells, tissue death, infarcted cells. Infarcted cells, meaning dead cells, they don't respond to electrical stimulus. So do those cells, does that muscle contract anymore? No, it does not. And that part of the muscle layer of the heart, in whichever portion that blood supply is feeding, just stops working. That's why when you get echoes and you look at an echocardiogram of a person that's had a heart attack, normally you get this good squeeze, right? And you get this kind of concentric squeeze on those chambers. When they've had a heart attack, only one part of that muscle will move, and the other part will just, there's nothing, depending on how bad the heart attack is. And that muscle never comes back, right? So it just depends on whether or not the rest of the heart can make up for it. If there's enough muscle that's dead, then that person's not going to come back, right? All right, we talked about autonomic. So chronotropic effect, there's a difference between chronotropic and inotropic, and this will be important when you guys start to learn about medications and more medications of the heart, because different medications affect different aspects. Some will affect just the heart rate, some will affect just the contractility, some will affect both. So chronotropic is the heart rate, right? What's a good chronotrope blocker? Metoprolol, good. Propranolol does both of the beta receptors. Metoprolol is selective and just does the one that's in the heart and not in the lungs. Inotrope is contractility. Can you think of a good inotrope? Or a medication that has good inotropic effect?
Oh, everyone.
Yeah, dopamine. Epi does both, right? Chronotropic and inotropic effect. And depending on the concentration, can do one more than the other. Dromotropic, I think that was just added on for fun. You don't really hear dromotropic very often. But this is just affects the conduction, is the electrical system. And I can't even think of anything that, I mean, that's really just electrolyte balances that'll have dromotropic effects. Baroreceptors, that can be thought of as pressoreceptors. We talked about these, right? Baroreceptors, they tell the difference in what? Your blood pressure, right? And they're found in carotid arteries, aortic arch, where it's important for you to have accurate blood pressure, right? And if there's a change, it sends a signal and it tries to change it so that the blood pressure is what it wants it to be. Chemoreceptors. Chemoreceptors are, they do oxygen, or they can detect oxygen content, pH, and carbon dioxide. What do you think is more sensitive? The oxygen receptors or the carbon dioxide receptors? Carbon dioxide, good. So changing carbon dioxide will change physiology much more than the oxygen will. Parasympathetic, most of this comes from the vagus nerve. We know this, right? Vagus nerve. So which chemical is released at that synapse? Acetylcholine. Good. And that's also called, the receptor is called a what kind of receptor? Cholinergic receptor. Good. So vagus nerve innervates both SA and AV nodes. We talked about that. Acetylcholine, main effect is it slows the heart rate. Sympathetic stimulation. So this comes from your thoracic spine and those sympathetic ganglion. Primary neurotransmitters, norepinephrine, and those are what kind of receptors? Adrenergic. So these are the receptor sites. Quick kind of overview. Alpha-1 is in the eyes, and what does it do if alpha-1 is stimulated? Constriction. So constriction of pupils, constriction of, let's see here. And then we, of course, alpha-2 is digestive for the most part. Beta-1, that's your heart and your kidneys. Beta-2 is in the lungs. And then your dopaminergic receptors as well. And excuse me, alpha-1 causes vasoconstriction, but it wouldn't cause pupillary constriction, right? So if you got vasoconstriction, that's a sympathetic response. And in a sympathetic response, what happens to your pupils? Dilate, right?
Okay, thank you. I was in the book that we had this conversation.
Right. All right. Heart as a pump. So the most important factor in the pump is it can't do anything if it's not getting anything, right? So it's venous return. Blood pressure is the force pushing out on the walls of the arteries. So peripheral vascular resistance, you guys will hear a lot about this. Peripheral vascular resistance is your cardiac output times, blood pressure is your cardiac output times the vascular resistance. What are factors that contribute to vascular resistance? What's that?
Cholesterol.
Okay, so atherosclerosis will increase your peripheral vascular resistance. Normal, healthy individual. I guess it's kind of a trick question, but it's just the diameter, right? So the diameter of the vessel will be the biggest contributing factor to the resistance of that vessel. So cardiac output is the amount of blood going from the heart in 1 minute, right? So it's the heart rate times the stroke volume. Stroke volume is how much blood is ejected from the heart with one heartbeat, and then over a minute tells you how many heartbeats. That gives you the overall cardiac output. You guys know all this stuff. Let's see. So big factors affecting venous return, of course, hypovolemia, and then heart failure. Heart failure increases your preload. This gives you that Frank Starling, right? The more stretching of the heart, the greater the contraction. You guys knew that. Afterload. What is afterload?
The amount of blood remaining in the heart after contraction.
pressure that my ventricles have to pump against.
Okay, yeah, so it's the pressure that the heart is pumping against. That's the afterload, right?
Essentially
So we talk about medications that decrease afterload or increase afterload. If you're increasing your afterload, you're increasing your peripheral vascular resistance, right? You're increasing the pressure that the heart has to pump against.
diastole, right? Is what it's going to be, correct?
You mean,
If we have an increased diastolic BP, that means we have an increased afterload, correct?
yes, yes. You can have increased afterload in systole as well. So if you've got atherosclerosis, that increases your afterload, right? And then chronically high blood pressure increases, that causes arteriosclerosis, right? It makes all the muscles a little bit thicker because there's increased pressure pushing on them. So they compensate by increasing its walls. That increases the peripheral vascular resistance, increasing your afterload, increasing the work on the heart. And then the heart has to increase its muscle, right? Because it's pushing against this greater afterload on a regular basis. So the left ventricle muscle starts to become bigger to make up for that, correct? And that's when you get LVH. And you would think, oh, bigger muscle of the heart, isn't that a good thing? Why is it not a good thing? So you get decreased filling, right? You've got increased muscle there that's taking up space. You got decreased filling, so it decreases the effectiveness and the overall efficiency of the heart. Good. All right. So yeah, cardiac output, anything that affects heart rate or stroke volume. So decreased cardiac output in a patient, this is what you're going to see from a clinical standpoint. Cold, clammy skin, dyspnea, orthopnea, crackles, that's what we talked about, rails, your pump's not working very good, it backs up into the lungs, change in mental status, blood pressure, dysrhythmias. Why does it cause a dysrhythmia? I can't hear you.
Thank you.
Dysrhythmia means poor rhythm versus arrhythmia. Technically, it's not having
Yeah, arrhythmia. You have, most of the time it's transient arrhythmia, right? Where you have like skipped beats or whatever. Dysrhythmia is it's just kind of out of whack. There's no pattern to it or whatever. So if you have decreased cardiac output, you're decreasing your blood flow to the coronary arteries. Coronary arteries feed cardiac muscle cells, but also feed your conduction cells, right? So all of those AV blocks, all of those conduction deficiencies usually are caused by heart disease because there's decreased blood flow. It's a heart attack. It's basically a heart attack to those cells. All right, you guys can take a break. Questions? Found it for everyone. So we just ignored it and didn't tell him. And it all turned out fine. It was a Christmas miracle. No, but my wife was making a joke of it because 2017 hasn't necessarily been kind to us. And she was like, we had to just slide something in at the last minute just to kind of cap off our year.
You got that deductible.
Yeah, that's true. We definitely met the deductible. No, actually, it didn't work because tricky insurances, they have an individual deductible and then a family deductible. And nobody else got hurt that year, so And he hadn't met his individual deductible, so it didn't matter the hundreds of thousands of dollars I had racked up. We
why
still
don't
had
you
to pay. We still had to pay
Get
for
some
his
cast material, bring it home, and just do it.
because I needed the X-ray to know, So
Sneak them in at night.
and I didn't know. I know, right?
It's cheaper at the airport.
That's right. Yeah, you did it when you flew.
I probably could have taken him to the ER and then just like taken him to, radiology. Be like, hey, they probably would have done it, but then I would have felt like one of those guys.
Your
But
wife's okay with it.
yeah,
And when you're saying you didn't trust AMR to come to your house,
Again, it's not an emergency, remember?
yeah, it wasn't an emergency.
Well, no one else cares.
No. Yeah, right. All right. Some of this is going to be review. Hopefully some of it will be new. But you guys know 2 different cells, myocardial cells, pacemaker cells, and what they do, right? We don't need to go through that. Automaticity we've talked about in length. We'll talk about it again because everything on an EKG has to do with the conduction system, right? So automaticity is going to be important. But that's the set default setting of the pacemaker cells, right? And each cells have a different pacemaker, and as one gets knocked off, it goes to the next, and the next pacemaker setting is just slower. Excitability, sometimes it's called irritability, is just the response to stimulus. And some people's hearts are more irritable, but certain medications cause irritability as well. So that's why that term is useful. Conductivity, of course, is the conduction of the electrical stimulus. And the conductivity is cell to cell through those gap junctions, right? Contractility is the contraction force as in response to the electrical stimulus. So conduction system, it gives you a little picture of the cars and, which one's faster, which one's slower. So specialized pacemaker cells, your primary pacemaker, your fastest default setting is in the SA node.
just to let you know, we don't have that slide, so I don't know if we have the next. Oh, it's, never mind.
Basically what that means is that the slides that you're looking at that I don't have, I cut out because we're less important. So you guys have 180 slides. I cut it down to 91. So you guys are going to have twice as many slides as what I want you to have. So you can just start crossing out slides if I skip over it. All right? Unless you want to have the extra knowledge and studying. But I'll make sure Gary knows the testable material. Atria. So this is where the SA node is, right? And then the AV node is right in between the atria and the ventricle, right? But fires an SA node, and then also from the SA node, obviously is surrounded by muscle tissue and the electrical system. The impulse goes down through the electrical cells, but also goes through the muscle cells, cell to cell through those gap junctions.
That picture shows the SA and the AV node connected,
Mm-hmm.
like nerves or something, but it actually just connects through the atrial muscle. Is that right?
No, both. So the SA node is connected to the AV node through pacemaker cells, through specialized electrical cells, and that's why it's fast, right? That's why it gets all the way down to the Purkinje fibers before it ever goes through the muscles, because cell to cell it's slow. So if you take out the electrical conduction system, then it truly is just through the muscles, and that's when you get that really widened QRS, because the electrical impulse or the depolarization of all those muscle cells is slow. because it has to wait for the connection through all the muscle cells. Does that make sense?
Yeah.
So we'll talk about that on the EKGs too, and why EKGs change and what that means when they do change. So the impulse goes to the AV node via the internodal pathways. So that's those special electrical cells. Let's see. So that's the AV node. And then from the AV node, you got the bundle of His, and then down into the bundle branches, right? And that's the bundle branches are where in the heart? Septum. Good. So the AV node is the floor of the atrium. That AV node is supplied by the right coronary artery. So that's why those, if you've got a blockage in the right coronary artery, it takes out the AV node. It'll do what to the heart rate? Slow it down. Good. And it'll also delay the response, right? And oftentimes, depending on where that injury is, then the atrium and the ventricles start to beat independently. They don't wait for each other because the electrical system gets messed up.
So if the AV node doesn't pick up a signal from the SA node,
Mm-hmm.
the only way that the signal is going down is through the muscle tissue. Correct?
Mm-hmm.
So then does it enumerate it there in the bundle? Does it kind of bypass the AV, so it's delayed to hit the bundle, and the bundle takes the signal down?
Well, no, the bundle has its own automaticity.
So that's what would take over?
That's what takes over. So if it's not getting an impulse from above, it starts going off its own automaticity, which is slower, but then it's kind of beating independently, and there's still contraction through the muscle cells, but it's started at a different place. If the bundle branches are what's starting the heartbeat, then that electrical impulse starts there and then spreads from there to the rest of the muscles. So that means the atria oftentimes will contract after the ventricle, and it'll be completely messed up.
So the whole, like the bundle and all those, they can't receive an outside electrical impulse from the muscles, can they?
No,
Okay.
they're based on their own default setting unless they're getting an impulse from higher up, but not from the muscle cells. They send out signal to the muscle cells, but not in reverse. Because the muscle cells, they can only respond from an outside stimulus.
It's either through the internodal pathways or the specific spot. Yeah.
Right.
Okay.
Yeah. All right. So yeah, we talked about this. So if you've got injury to that area, it just delays the conduction of the impulse because it has to go through all the muscles instead of that internodal pathway. Now, in normal circumstances, you've got a little bit of a delay because the SA node is faster, right? And that signal is sent down at a certain rate, but then when it hits the AV node, the AV node's not as fast, so it delays it a little bit, right? And that's why the atria has time to contract milliseconds before the rest of the heart contracts because of that delay in that impulse. Let's see. So we got the bundle of His. This is after the AV node, and they have bundle of His has a different intrinsic default rate, and then goes to the bundle branches. Bundle branches have a different intrinsic rate, 20 to 40, and that's where your Purkinje system is, which is why in a complete heart block, so complete heart block is when it's taken out both bundle branches and your automaticity is only coming from the Purkinje fibers. So the atria is beating independently from the ventricles, and that ventricular beat, which is actually what you're feeling in a pulse, right? You don't feel the atrial contraction, you only feel the ventricle contraction, and that's why that pulse is so slow, because the Purkinje fibers are only beating at 20 to 40. The atria still might be beating at 70, 80, but independently from the ventricles because the connection's been lost. So you can have injury to the septum that takes out those bundle branches, but it didn't injure the SA node. The SA node's still going at its default setting, but it's not connected to the Purkinje fibers in the ventricles, right? So that's why it's independent. Does that make sense? So this is a PQRST and kind of shows you which portions of that or comes from the different intranodal pathways. So the SA node fires, but there's just a very, very, very quick delay in the firing of the SA node and then the muscles responding to it. The contraction of the atrium is the P wave, right? And then it gets down to the AV, and there's a little bit of a delay, and that's that PR segment before the QRS. Now,